సో ఏడిహెచ్ అంటే ఏంటి అంటే డైరెటిక్ హార్మోన్ అనమాట. ఎవరు రిలీజ్ చేస్తారు ఏడిహెచ్ని? హైపోథలామస్ ఏడిహెచ్ని రిలీజ్ చేస్తే అది సెక్రెట్ చేస్తే అది పోస్టీరియర్ పిట్యూటరీ గ్లాండ్కి వెళ్ళి స్టోర్ అవుతుంది. ఎప్పుడైతే ప్లాస్మా యొక్క ఆస్మోలారిటీ ఇంక్రీజ్ అవుతుందో అంటే ప్లాస్మాలోని ఐ మీన్ బ్లడ్లోని కాన్సన్ట్రేషన్ ఇంక్రీజ్ అవుతుంది అంటే వాటర్ కంటెంట్ డిక్రీజ్ అవుతుంది ఇండైరెక్ట్గా, అప్పుడు ఏడిహెచ్ రిలీజ్ అవుతుంది అనమాట. వెళ్ళి ఇది ఎక్కడెక్కడ యాక్ట్ చేస్తుంది అంటే 3 ప్లేసెస్లో యాక్ట్ చేస్తుంది. V1, V2, V3 రెసెప్టార్స్ మీద. V1 రెసెప్టార్ బ్లడ్ వెసల్ మీద ఉంటుంది అండ్ ఇట్ కాజెస్ వాసో కన్స్ట్రిక్షన్, వేరాజ్ V2 రెసెప్టార్ ఈస్ ప్రెజెంట్ ఆన్ ద కలెక్టింగ్ డక్ట్. ఓకే, కలెక్టింగ్ డక్ట్ మీద యాడ్ చేసి అక్వాపోరిన్స్ని ఎపికల్ మెంబ్రెయిన్ మీద ఇంప్లాంట్ చేసి వాటర్ రీఅబ్జార్ప్షన్ చేసి ప్లాస్మా ఆస్మోలారిటీని తగ్గిస్తుందన్నమాట. ఓకే, V3 రెసెప్టార్ వచ్చేసి మనకి పిట్యూటరీ గ్లాండ్ మీదనే ఉంటుంది అండ్ ఎప్పుడైతే ఏడిహెచ్ రిలీజ్ అవుతుందో అట్ ద సేమ్ టైం పిట్యూటరీ మీద యాక్ట్ చేసి అదే ఏడిహెచ్ ACTH ప్రొడ్యూస్ చేస్తుంది. బట్ విల్ నాట్ డిస్కస్ మచ్ అబౌట్ దిస్ టాపిక్ ఆన్ V3 రెసెప్టార్. Now we will discuss about the pathology related to the ADH. Okay. What is the pathology related to the ADH? You know, yes. SIADH, diabetic insipidus and etc. So first we will discuss about the SIADH. SIADH అంటే ఏంటి? సిండ్రోమ్ ఆఫ్ ఇన్అప్రోప్రియేట్ ADH ప్రొడక్షన్. ఎనీ ట్యూమర్స్ నుంచి కానీ ఎక్కడ నుంచి కానీ ఎటువంటి కంట్రోల్ లేకుండా ADH ప్రొడ్యూస్ అవుతుంది. సో అలా ప్రొడ్యూస్ అయినటువంటి ADH కంటిన్యూస్గా కలెక్టింగ్ డక్ట్ మీద యాక్ట్ చేసి వాటర్ రీఅబ్జార్ప్షన్ అయ్యేలా చేస్తుంది. అలా చేయడం వల్ల మనకి డైల్యూషనల్ హైపోనాట్రీమియా అవుతుంది. ఎప్పుడైతే బ్లడ్లో వాటర్ కంటెంట్ ఇంక్రీజ్ అవుతుందో మనకి ఫిజియోలాజికల్గా మనకి ANP ప్రొడ్యూస్ అవుతుంది, యాంటీ నాట్రియూరెటిక్ పెప్టైడ్. ఓకే, సారీ ఏట్రియల్ నాట్రియూరెటిక్ పెప్టైడ్ లేదా BNP, బ్రెయిన్ నాట్రియూరెటిక్ పెప్టైడ్ అనమాట. సో ఈ ANP, BNP ఏం చేస్తాయి అంటే యూరిన్లో సోడియం ఎక్స్క్రీషన్ అయ్యేలా చేస్తాయి అన్నమాట. ఓకే, అట్ ద సేమ్ టైం వాటర్ కూడా ఎక్స్క్రీట్ అవుతాయి సోడియంతో పాటు. అలా బ్లడ్లోని వాల్యూమ్ అయితే తగ్గుతుంది కానీ సోడియం ఇంకా తగ్గుతుంది అనమాట. దట్స్ వై మనకి యూఓలిమిక్ హైపోనాట్రీమియా వస్తుంది. అట్ ద సేమ్ టైం మనకి నాట్రీమియా ఉండడం వల్ల ఇప్పుడు సోడియం రిటెన్షన్ అవ్వాలి కదా, సో ఆల్డోస్టెరాన్ ప్రొడక్షన్ వాటర్ రిటెన్షన్ అయిపోయింది కదా, సో హై వాటర్ కంటెంట్ ఉండడం వల్ల బ్లడ్లో మనకి ఆల్డోస్టెరాన్ అనేది తగ్గిపోతుంది అనమాట. ఎందుకంటే సోడియంతో పాటు వాటర్ కూడా రీఅబ్జర్వ్ అయిపోతుంది కదా, సో ఫిజియోలాజికల్గా మనకి ఆల్డోస్టెరాన్ తగ్గిపోతుంది. ఓకే, సో ఇప్పుడు మనం చూస్తే ఇక్కడ ఒక పాత్వే ఉంది, ADH పాత్వే. సో ఈ ADH పాత్వేలో మనం చూస్తే కనుక SIADHలో ADH ప్రొడక్షన్ ఇంక్రీజ్ అవుతుంది, వేరాజ్ నార్మల్లీ ఫిజియోలాజికల్లీ ఇన్ high levels of ADH, lithium and nephrogenic diabetic insipidus. In all these conditions there is inhibition of ADH production. Okay, so now if we are going to the clinical features, how the patient present with the SIADH. Just now we talked about hyponatremia. There might be euvolemic hyponatremia or hypervolemic hyponatremia and urine osmolality. As ADH, what it will do? Water reabsorption. So urine osmolality increases, yes, than serum osmolality, and urine sodium levels increases more than 20. Okay, in SIADH there will not be so urine sodium less than 20. And let's see what are the causes of this SIADH. Okay, if we are going to see the causes of SIADH, we can what can we do? We can keep an abbreviation like mnemonic healed up water. Okay, it's HEELD, healed, not HEE. So H means head trauma, CNS disorders. In head trauma or CNS disorders also there will be increase in ADH production, and in ectopic ADH production like small cell carcinoma of lung, and E for exogenous hormones like vasopressin, desmopressin and oxytocin, and L for lung diseases, and D for drugs like SSRIs, carbamazepine, and cyclophosphamide. Okay, SSRIs, selective serotonin reuptake inhibitors, carbamazepine, and cyclophosphamide. All these drugs also causes SIADH. What are the causes of SIADH? Heel aperture. H for heteroma CNS disorders, E for ectopic ADH like small cell carcinoma of the lung. Again, one more E for exogenous hormones like vasopressin, desmopressin, oxytocin, and L for lung diseases. D for drugs like SSRI, cyclophosphamide, and carbamazepine. Then, how can you diagnose that it is the SID-ADH? For that, we will do a test known as water loading test. In normal cases, if we will load the body with water, what will happen? Okay, what you will get? ADH production should decrease, but in case of SIADH, still there is increased levels of ADH that is suggestive of SIADH. So what is the treatment for SIADH? Treatment for SIADH is obviously fluid restriction, because there is more fluid in the body now, and sodium correction because of hyponatremia, and Vaptans like selective V2 receptor inhibitors like conivaptan, tolvaptan. But because of Vaptans, there is increased risk of hepatotoxicity. So we will not use them for more than 1 month duration. Only transient usage. And one more drug, you know this, that is demiclocycline. You can get it out. What? Tetracycline antibiotic. Why we are using it in SIADH? Why? Because this demiclocycline has a property known as inhibiting adenyl cyclase activation after binding to ADH. After ADH bind to V2 receptor in the collecting duct. Okay, what ADH will do? It will go to the collecting duct and it will bind to V2 receptors. Okay, everything is fine now. But after that, adenylyl cyclase should get activated to implant aquaporins on the apical membrane. But because of this demiclocycline, this adenylyl cyclase is inhibited. That's why ADH action is not going to take place now. So we can also use demiclocycline in SIADH. What is the treatment for SIADH? Fluid restriction, sodium correction, Vaptans, and demiclocycline. So all these about the SIADH. Okay, you got to know now. Next, we are going to discuss about diabetic insipidus. Okay, so what is diabetic insipidus? There is polyuria. That is urines, because of this polyuria, urine specific gravity will become less than 1.006 and urine osmolality will become less than 300 milliosmol per kg. It is opposite to SIADH. In this, either there is there is absence of ADH, or there is no reaction of there is no response to the ADH. So first, will come like a clinical case. So, a patient came us with the polyuria, more than 3 liters of urine output per day, or more than 40 ml per kg per day. Then, what you will do commonly? You will go for, you will check, you will send for urine analysis. There, you will check for urine osmolarity. If the urine osmolality is less than 280 milliosmoles per kg, then you can go for, you will have a doubt about ADH production, then you can go for ADH assay or copeptin assay. Copeptin is it's a part, or it's a piece of the ADH. So when you will do that ADH assay, if we are giving ADH to the diabetic insipidus patient, and ADH levels are increasing now, then it is nephrogenic diabetic insipidus. That is, I mean, so it is improving now, then there is nephrogenic diabetic insipidus. That is, the problem is not in ADH production, the problem is in the in the kidney. Whereas if it is decreasing, that is central diabetic insipidus, that is the ADH is already present, but sorry, here ADH production is absent. Okay, that's why polyuria is decreased. Okay, whenever we are giving ADHSA, now I got a doubt, yeah. Okay, ADHSA or copeptine assay, if it is improving, then it is nephrogenic diabetic insipidus. If it is not improving or it is decreasing, then central diabetic insipidus or polydipsia. Okay, now if it is central diabetic insipidus or polydipsia, then if to differentiate them, we should go for MRI. In MRI, if the posterior pituitary bright spot is absent, then it is central diabetic insipidus. If it is present, it is normal, that is patient is taking more fluids, that's why he is having polydipsia. That also leads to hyponatremia, that is due to excess water intake, dilutional hyponatremia. Okay, now how can you differentiate nephrogenic diabetes insipidus and the central diabetic insipidus? If you are giving for that you should do desmopressin test. In desmopressin test, if you are giving desmopressin, which is similar to vasopressin or ADH, if the urine osmolality is increasing, if urine osmolality is increasing, then it is suggestive of central diabetic insipidus, that is there is no ADH in the body, that's why there is polydipsia, polyuria, sorry. And if urine osmolality is decreasing, still there is decreased urine osmolality, then it is suggestive of nephrogenic diabetic insipidus. Okay, in both cases there is hypernatremia, whereas in polydipsia there is hyponatremia. Then how can you differentiate all these? Primary polydipsia, central diabetic insipidus and nephrogenic diabetic insipidus. In primary polydipsia, there is excess water intake. In central diabetic insipidus, there is decreased ADH release. In nephrogenic diabetic insipidus, there is resistance to the ADH. And what are the causes of primary polydipsia? In some psychiatric illnesses, or like any hypothalamic lesions affecting the thirst center, they repeatedly take water, that leading to polyuria. Okay, next, in central diabetic insipidus, what are the causes? It is mostly idiopathic in some cases, like brain injury, trauma, hypoxia, tumors, any surgery, any infiltrative diseases causes central diabetic insipidus. Nephrogenic diabetic insipidus is mostly hereditary. In this case, there is ADH receptor mutation. That's why the ADH can't act on the ADH receptors. Drugs like lithium and demiclocycline, you know now demiclocycline, it makes the adenyl cyclase inactivation. Okay, like that there is nephrogenic diabetic insipidus. Hypercalcemia and hypokalemia also causes nephrogenic diabetic insipidus. Next, serum osmolality. Obviously, in polydipsia, he is taking more water, so serum osmolality decreases. But in central diabetic insipidus and nephrogenic diabetic insipidus, there is no action of ADH, so no water uptake. So serum osmolality increases. ADH level in polydipsia may be decreased or normal, but in central diabetic insipidus decreased, whereas in nephrogenic diabetic insipidus mostly increased or normal. Water restriction. If we are restricting water in primary polydipsia, there is significant improving in urine osmolality. Okay, it become more than 700 milliosmol per kg. Whereas in central diabetic insipidus, there is no change or there is slight increase in urine osmolality. Same in case of nephrogenic diabetic insipidus. And this is water restriction test. If you are doing a desmopressin test, no change in polydipsia. In central diabetic insipidus, there is increase in urine osmolality because there is ADH deficiency in this. Whereas in nephrogenic diabetes insipidus, there is no much change. because already there is ADH. Not there is no problem in the ADH in case of nephrogenic diabetic insipidus. Next, serum sodium. In primary polydipsia, there is decrease in serum sodium, hyponatremia. Okay, dilution or hyponatremia. Whereas in central and nephrogenic diabetic insipidus, there is hypernatremia. In primary treatment, in primary polydipsia, we should go just tell him not to take water. So water restriction in central diabetic. So ADH is absent. We will give desmopressin to him. In nephrogenic diabetic insipidus, you will first treat the underlying cause. Tell him to take low sodium diet, and you can also give like inactive channel blockers like amiloride. Therefore, there is no water reuptake. And sorry, sodium reuptake. That's why we can decrease hypernatremia, and you can use indomethacin also. And the most important treatment here, hydrochlorothiazide. You can prefer thiazides in nephrogenic diabetic insipidus to decrease serum osmolality. So this is diabetic insipidus. Okay, so with this I'm signing off. Bye. This is Dr. Nikita. Bye.